Thank you very much. It is truly a pleasure to be here, Pooja, and the Youthful chapter of IRSI. I think I would like to say that actually, Sir has made my job very easy with his presentation because I think all the points that he spoke about are actually in favor of the fact that dry eye as a subspecialty is a hype. It is something that we all deal with day in and out. So we are we trying to move towards this? That we want a super specialist, a subspecialist for like literally every single thing? And are we trying to include even dry eye into a subspecialty? And I think absolutely not. According to me, what is the definition of subspecialty? A subspecialty is a specialty within a within a specialty. It's a narrow field of professional skills. It requires more complex situations which a generalist is unable to manage. And generalist sees much less of these cases in their own practice. Plus, it requires months to years of separate training or building that experience. And let's look at dry eye in general ophthalmology practice. And Dr. Kumar has already spoken about that. So I would like to thank you, sir. You've made my job much easier. It's a very, very common problem. More than 50% of patients in general ophthalmology clinic actually have some form of dry eye. Studies have also shown that 25 to 50% patients which are undergoing cataract surgery, and cataract surgery really is the bread and butter of general ophthalmology, have some form of dry eye. And 38 to 75% of patients who are undergoing refractive surgery have some form of dry eye. Let's look at the bread and butter only. So those patients who have dry eye, and this is something which affects not just the postoperative outcomes, but even the preoperative planning. As Sir has shown in one of the topographies, that how if your surface is dry, then even topography values may not be correct. So, of course, that can affect your biometry readings and other things. And he also showed that one of the leading causes after multifocal, the dissatisfaction, is actually preoperative and postoperative dry eye. So, cataract surgery, and by itself, it also is a cause as well as it worsens the dry eye disease. So, it is very important as general ophthalmologists to identify, treat, and educate these patients prior to surgery. And when you do that, patients actually understand that a lot of times these postoperative symptoms are due to their pre-existing disease. So when this topic was given to me by Pooja, then I said, okay, let's look at our own data. Since we are a multi-specialty eye clinic and we see all segment of patients, so we realized that even 50% of patients that are coming to our clinic have some form of dry eye. However, 80% of these patients had only mild or mild to moderate dry eye. Of these, 62% patients had meibomian gland disease. 40% patients had excessive gadget use, as was already shown by Dr. Kumar. 50% of patients undergoing cataract surgery had dry eye, and 40% of patients for refractive surgery had dry eyes. And the 20% patients who had actually severe dry eye were the ones who were referred from outside for the cornea department. So this was our data. So now let's apply the definition of subspecialty to dry eye. First of all, dry eye is not an uncommon problem. It is a very, very, very common problem. Like almost 50% of patients that we see today have some or the other form of dry eye. It does not require months to years of training. And it is very easy to integrate into our clinical practice for any ophthalmologist and any general ophthalmologist. Let's look at how we can integrate, right? It's very simple. As ophthalmologists, we always are taking history and we are always asking questions. We have certain simple diagnostic tools or tests that we use for any kind of diagnosis, whether it's cataract or whether it's anything. And then we have a simple treatment plan for managing everything. Same thing can be very easily applied to managing dry eye patients. I'm not going to go into detail because I think the details will be covered in the subsequent talks. But history taking, now this is something that I have just taken from Views too, but literally history taking basically involves just trying to identify the symptoms, how severe they are, when they started, associated symptoms, and if there are any associated risk factors like contact lenses, etc. And in the diagnostic, we don't need very fancy diagnostic tools. We don't need, a lot of fancy diagnostic tools, which could be useful for very severe cases or which could be useful for research purposes. But in all daily practical, for all our practical purposes, all we require are 4 basic tests, which is tear film breakup time, surface staining, Schirmer's test, and just assessing the meibomian glands. Again, I will not talk about this. I think this will get covered. We all are aware about tear film breakup time, surface staining, Schirmer's tests, meibography. Now, a lot of times patients worry that how are they going to do meibography? Meibography can be very simply done on an AR machine. And basically what we are trying to look at is just the fact that how much is the dropout rate of the meibomian glands, and that can help us in deciding the treatment, right? So really no specialized skill sets needed. Everybody knows how to take a good history. Everybody knows these very 4 basic tests that can be very easily performed by anybody. And treatment, it's a very nice protocol that is there, which starts with simple education and starting lubrication and moving upgrading to the next step based on the response that we see, right? So really, if you look at the whole thing, it was very simple. But what challenges do general ophthalmologists really face when it comes to managing dry eye, because of which we are even talking about dry eye being the subspecialty, right? A lot of times, general ophthalmologists feel that we have busy OPDs, these tests are time consuming. Who will perform these tests? There is often a mismatch between signs and symptoms. We don't want to manage complicated dry eye. And often the chair time that is being spent with the patient is actually not lucrative enough. So I don't want to do this, right? So these are some of the challenges that we may face in our general ophthalmology practice, because of which we may don't want to deal with these Khujli-Pani patients, so-called Khujli-Pani patients. But we did one experiment. Just 2 months before lockdown, we actually got one dry eye comprehensive diagnostic machine, because some of these challenges we were also facing. So this dry eye diagnostic machine was actually giving us a good report, which was basically showing us the tear film breakup time, the tear meniscus height, lipid layer using interferometry and meibography. And we made it mandatory for everyone who had symptoms suggestive of dry eye, pre-cataract workup, and LASIK workup. And those who showed abnormal reading on this test then underwent a surface staining with fluorescein stain. So first, what we realized was we had some really interesting insights that it made it much easy to explain and counsel to patients who had abnormal results. There were much better acceptance of the treatment. Cataract surgery patients, when they were counseled about the potential need for dry eye treatment in future, there was much better acceptance. Patients with significant meibomian gland disease, but having less dropouts, were counseled for IPL treatment. Significantly better value of time spent. And the potential revenue that was generated we did in those 2 months, this test was performed on 250 patients, and we charged 500 rupees per patient. So 1,25,000 revenue generated from just the diagnosis. And the IPL machine, which can be easily hired, it's actually available on rental. And we just did 5 patients, each requiring 2 treatment, 4,000 per treatment, so 40,000. So literally, if you see that in just those 2 months, it actually helped us in streamlining the whole process very, very easily. Um, so really, like, this dry eye management is a very, very easy to integrate. Simple history questionnaire, which can be delegated to the optometrist. Those with symptoms suggestive of dry eye, you can just perform the 4 basic tests. If you have a good OPD load, you can just buy the comprehensive dry eye diagnostic machine. You can manage as per disease severity. And for severe complicated cases which have systemic associations, catechal dry eye, etc., can be easily referred so that you don't have to worry about managing them. So I'd like to conclude here. It is a very common problem in general ophthalmology. The diagnosis and treatment can be very easily integrated into general ophthalmology practice. There is no specialized skill sets or training needed. Basic tests are enough for diagnosis. And dry eye diagnostic machine can help streamline busy OPDs. Complicated severe cases can be referred to ocular surface specialists. So I'll end by saying that we don't need more specialists. We actually need the generalists, because when we are managing day-to-day situations like cataracts, refractive surgery, or even our basic OPDs, we need people to be thinking more holistically rather than only thinking about one particular thing. Thank you very much.